So my name is Dr. Dalsi Wanda, a clinical oncologist, SHO, at the Kenyatta National Hospital in affiliation University of Nairobi. So today we're very pleased to have the 9th chapter of the Oncology Conference of Nurses. Today we'll discuss about cancer of the esophagus. When we compare statistics in Africa and the West, cancer of the esophagus ranks quite high. We have a high incidence and we have a high mortality rate, which necessitates us having cancer awareness, getting to know about the risk factors, and ensuring that we have early diagnosis to ensure we have good outcomes for our patients. Welcome, join us for the conference, enjoy the session, and gather the knowledge and share it abroad. So good morning. I'm very pleased to stand before you today. Maybe just a bit of background about me. Sometimes it's good to know your presenter. So previously I really wanted to be a nurse. So I applied for nursing. In Nairobi Hospital. I went for the interview, I passed. I did the aptitude test, I passed. I went to the nursing board and they told me they will not allow me to do nursing because they felt I should do something else. So why did I want to be a nurse? My mother is a nurse, so I feel very much at home here. She is part of the reason why I'm in healthcare. I respect her. I value her. She's the reason I am who I am today. So maybe we can give a round of applause to my mom. So thank you. So maybe we can go to the talk for the day, Oesophageal cancer. We're going to look at the diagnosis, the treatment, and the care. So it's basically an overview because really oesophageal cancer is a very wide topic. We might not be able to exhaust everything today, but we want to have an overview. Why is this talk important? If we look at the statistics here in Kenya, we are able to see that esophagus is very high up on the rank. If we look at, perhaps if we look at the new cases, we see it is quite high. Particularly in the females, it's actually ranked number 3. These statistics are different from the West. The West, oesophageal cancer is not something they see every day. That means we have to have a high index of suspicion, and we'll see what we need to look out for. So like any talk in oncology, we begin a bit with the anatomy. So the esophagus is the tube that connects the mouth to the stomach. It's a conduit for food. And it's divided into about 3 parts. We have the cervical, which is within the neck region. We have the thoracic part, which can also be divided to upper thoracic, mid-thoracic, and lower thoracic, and we have an abdominal part. Why it's important to know these divisions is because management is different depending on the position where the lesion is at, and sometimes also the presentation becomes different. And then the esophagus has layers, so it's a tubular structure. It has an internal layer that is the mucosa, then we have the stud mucosa, then we have the muscle layer, and then we have adventitia. Of note is that the esophagus does not have a serosa. Serosa is the tough outer layer of the esophagus that would have helped the disease not to penetrate through. So the lack of the serosa means that the structures that are very close to the esophagus can easily get disease. So our questions were always asked, what are the risk factors? What should someone look out for? So one is heavy drinkers have been known to be at a higher risk. Habitual smokers, those who have gastroesophageal reflux disease. Why is this important? Majority of the patients, when they come to the oncology center, sadly, for cancer of the esophagus, they present in stage 4. However, they have come to hospital many times, and we've managed them for ulcers, neck pain. These are our friends who, when they are stressed, they have hyperacidity. This is us who say, I have ulcers, I have hyperacidity. So it's really important if you are having ulcers or hyperacidity, or you're taking omeprazole, self-medicated, because we do that a lot as healthcare workers, it is important for us to know we are at a risk of getting esophageal cancer. Those with Barrett's esophagus, what is Barrett's esophagus? We're talking about a condition where the cells of the lower part of the esophagus, they've changed, they're not normal, and they become those that resemble the stomach. If you're obese, then you have a higher tendency to have reflux, which is a risk factor for cancer of the esophagus. Those with esophageal strictures, maybe you have narrowing of the different parts of the esophagus, is actually a risk factor. If you have achalasia, where you have smooth muscle fibers of the esophagus not relaxing, that is a risk factor. So diagrams work best. So that's just to help us understand what are the signs and symptoms. So the first one talks about difficulty in swallowing, where you feel that food is coming back, or you feel that for you to swallow, you need to have a glass of water. So previously, you would chew your food, saliva was enough, but now you have to have a glass of water to help the food go down. If you have persistent acid, indigestion, heartburn, or even reflux is a risk factor. If you have persistent cough, perhaps you have a lesion in the upper esophagus that is causing that to happen. If you have unexplained weight loss, you're not dieting, you're not going to the gym, but you're having weight loss, it's important to think about cancer of the esophagus. So when we talk about imaging, primarily in this setting, the imaging that is done first is normally a barium swallow. When a patient complains, you'll find they'll present to a healthcare facility, in a tertiary facility with a barium swallow. And a barium swallow means there is barium, which is contrast. They take and they swallow. And immediately they swallow, an X-ray is taken. As you can see in the image of the X-ray towards the end, you're able to see here that there is a bit, okay, I don't have a pointer, but the last image there, you can see shouldering. It's supposed to be a continuous tube where the contrast is at. But you can see there is a hold up and then an area of irregularity and then normal esophageal mucosa. So that is a sign that you should be able to suspect that the patient has cancer of the esophagus. Some will present with a CT scan, and if you look at the CT scan, the area in red that I have highlighted is where the esophagus is. Remember, it should be a hollow tube. So if you see it's not a tube, it's a small dot or sometimes completely obliterated, then that would give you an indication. A PET scan would light up where the tumor is, and you can see within the chest cavity that they is lighting up at that area. So that slide is pretty busy. However, it's talking about diagnosis. So if you forget everything, remember the image in the middle. You need to have endoscopy done and a biopsy taken. In oncology, I think we say tissue is the issue. So if you don't have tissue, we don't say you have cancer. So if you look at other things, you take a good history, you want to do a physical exam, we want to know the family history because there's also a 10 to 15% chance that it could be familial. We've seen certain families where they've had high levels of cancer of the esophagus. We'll do imaging, as we've mentioned, a CT scan, a PET scan. That will help us stage the patient. Blood work, the complete blood count, and also a chemistry profile. There are other tests that are important, especially in metastatic disease, where we want to test for the MSI, the MMR, and PD-L1, because we have treatments that target those kinds of, if positive, we can target them. And also HER2 for metastatic adenocarcinoma. So it's good to remember that primarily there are two histological subtypes. Primarily there are just two. One is squamous cell carcinoma, and the second one is adenocarcinoma. Primarily, previously, most of the cases were adenocarcinoma, but in the lower esophagus, we're seeing a lot of adenocarcinoma. This is a question patients will always ask, what stage am I at? So to put it simply, because most patients complain our jargon or our language is very difficult, it's good to have early stage, local regional, locally advanced, and metastatic. That is easy for a patient to understand. Early stage meaning it's a very small lesion, it is only within the mucosa, it's less than 2 centimeters. When it's local regional, then you're talking about what the image shows, the second image. You can see the blue is the lesion, that's the cancerous lesion, and then the green dots are nodes. So when you have lymph nodes involved, and it's just around the region of the tumor, then we're talking about local regional or locally advanced. Then we have metastatic cancer. When we talk about metastatic cancer, it's, I think, clear. It's either gone to the liver, lung, a different organ altogether. So there are more detailed ways to stage and characterize. This is good for clinicians because it guides our treatment process. But even if we tell the patient you're stage 2B, it will not make sense to them. So let us try and use language that is easy to understand. Early stage, local regional, or metastatic. Then about survival, why is staging important in esophageal cancer? It gives us an assessment to know how long, or possibly how long will the patient live. So research has been done, and for those who have stage 0, meaning it's just at the lining of the mucosa, then we know that 100% of them have a good chance of survival if we do the right thing at the right time. Then when it's stage 1, then it's 80%. And you see, sadly, in stage 4, we have 0 patients in 5 years. That's really sad. We need to put advocacy campaigns to ensure they do well. So when we talk about treatment, it's really a multidisciplinary approach. Why? We need the medical part, we need the surgical, radiation oncology, and we cannot forget nutrition. Remember, it's what connects the mouth to the stomach. So if there is a lesion, then the patient will lose weight. The patient will not be able to tolerate any of our treatments. So treatment is based on the stage. It's based on the overall health of the patient and also the patient preference. I think medicine is getting to a place where you discuss with your patient. There is option of surgery, there's option of chemo and radiation, and you give the patient both, advantages of each, and the patient has a right to choose. And I think that's important for us to understand, because previously, doctors and the healthcare providers were pretty much considered gods, and what we said the patient had to follow. But it's important to give the patient the power to be able to decide, this is what I want done to my body. So this is something I think as a country we need to think about. How can we have endoscopic procedures? For very early stage disease, then we need to have endoscopic resection. We're not doing this in the country currently. And this is what would ensure 100% of our patients actually survive cancer of the esophagus. We have ablation that can also be used. We don't have it in the country. So I think for policymakers, it's important for us to think about how can we make sure we have endoscopic resection? How can we make sure we have ablation? Because it's for early cancer. And when we talk about surgery, it's important to understand what an oesophagectomy is. It means we're removing a part of the esophagus. And that gap will be filled by pulling the stomach up. So you'll find some patients have the stomach very high in the chest. And that is brings some side effects like GERD, like being uncomfortable. And that's actually is important for us to know so that we can manage. And also, if you see the image there, then it means the patient cannot eat much because the stomach is really small. So nutritionists and also our advice of the healthcare workers is very important. So the systemic treatment, we're talking about the chemotherapy and how it's done. So for radiotherapy, we have two main kinds. I think the first one, majority of us have been exposed to. We've seen the radiotherapy machines. We know how radiotherapy works. However, we have what is brachytherapy, and that's what I have in that image. So the applicator is the first image. The second image shows the procedure. So the tube is put in, and where the tumor is, radiotherapy is delivered. The advantage of brachytherapy in cancer of the esophagus, it's localized. So you don't have dose to the lungs. You don't have dose to the heart. You're just treating where the tumor is. And I think if many institutions can have these applicators, then it would really assist in the planning. And that's how the treatment planning works, especially for external B. You have to contour the organs that are close by and ensure that the dose is going to the tumor itself. So as I wind up, we need to know what is the evidence for using three modalities of treatment, especially for locally advanced. So for locally advanced tumors, we use chemo, radiation, and the chemotherapy is to sensitize, to make the radio work better. So we use chemo, radiation, and then surgery. So chemo is one, radiation is the second, and surgery is the third mechanism. So there is evidence, like the KGB 9781, and if you see the two charts, you see the trimodality, the three methods have a higher overall survival for the patients, as opposed to just having surgery for the patients. Then we also have the German phase trial, and pretty much it's the same thing. When you use chemo, cisplatin, and 5-FU to sensitize the chemo, the radiation, then it works very well, and the patients are able to survive. So there is proof that treatment using three modalities is the best care for locally advanced disease. For early disease, the endoscopic measures are important, which we do not have in the country. But as a reminder, remember, anybody with chronic gastritis, heartburn, they need to have an endoscopy done and a biopsy so that we can catch the tumors early. Thank you very much.